Good evening, good morning, good afternoon, wherever you are. Welcome to today's academic talk on HLA matching and donor selection for haploidentical hematopoietic progenitor cell transplantation. This is being hosted by Jeenomics Transplant Immunology Laboratory based in Chennai, and it's a part of the Neuberg group and is accredited by NABL and European Federation for Immunogenetics. Today we have with us Dr. Arthi Anand. She is a consultant clinical scientist in Histocompatibility and Immunogenetics, Department of Infection and Immunity Sciences at Northwest London Pathology, Imperial College of London, UK. Arthi has a doctoral degree in immunology from University College London and is a fellow of Royal College of Pathologists. Her role involves overseeing testing in the histocompatibility and immunogenetics lab and providing the critical interpretation of results and associated scientific and clinical advice to support transplantation. Arthi is a specialist to the advisory group of the H&I at the Royal College of Pathology, UK NICWAS, and a contributing author for British Society for Histocompatibility and Immunogenetics guidelines for HLA matching and donor selection and hematopoietic progenitor cell transplantation 2021. We are extremely grateful to you, Arthi, for accepting our request. This topic came up during a presentation made to a group of postgraduates and specialists involved in transplant medicine 2-3 weeks back. And we just thought maybe we should ask you because you are very, very familiar with the topic and you've been doing this day in and day out. So without much ado, I'm going to hand over to Arthi for the presentation. And a quick thing, please, if you have any questions, feel free to ask the questions, but type it in the chat box and we will coordinate and get you all the questions answered at the end of the presentation. We expect the presentation is to be for approximately 30+ minutes and followed by the Q&A. And at the end of the meeting, I'm sure we are going to take back a lot of information and we will have further discussions offline, maybe from Monday. Thanks a lot for joining, and please stay back, enjoy, and absorb whatever Arthi has to say. And Arthi, it's over to you, and you can share your screen.
Thank you very much. Good evening, all, although it's a dull grey afternoon in London today. Thank you for joining and for the opportunity to present to you. So I will start by sharing my screen. Please bear with me a moment. So if I could have some confirmation that you can see my screen. Brilliant. Thank you very much. Well, as Srini mentioned, I was asked today to talk about haploidentical transplants and the Imperial College stem cell transplant team, and I thought I would share our experience of HLA matching and donor selection. So just to set the scene about the program, so we are one of the largest and self-declared most innovative program in Europe. We are very lucky to be supported by a state-of-the-art cell collection and manipulation facility, which is called the John Goldman Center for Cellular Therapy. Some of you might have come across Professor Goldman, who was a pioneer in stem cell manipulation and processing. So the center is named after him. We perform between 180 and 200 transplants per year. Transplants are allogeneic transplants, are principally for the common diagnosis, acute and chronic leukemia, myelodysplastic syndromes, lymphoma, etc. You might be surprised to see multiple sclerosis, which is an unusual component of our portfolio. the program supports both an adult and a pediatric immunodeficiency program, both of which are supported by my lab, which is Histocompatibility and Immunogenetics. So as you can see in the slide, we are based in West London, around the Hammersmith, Charing Cross. We serve 6 patients who are registered in 6 hospitals. And as you can see in this map of London, which is from the 2011 census, but hasn't changed much since then, it's very much represented with Asian and Black populations. And there's hardly any white populations we serve in terms of the transplant program. So this, of course, presents a lot of challenges for us when trying to identify matched unrelated donors. 10 on 10 matched, which is our criteria, alongside DP permissive matching. So it becomes very challenging to find these patients, donors, within the time frame required and appropriately matched. So this then is a nice slide that nicely represents the challenges we face. So this is a CIB-MTR slide from a few years ago, but the messaging still stands. So as you can see in this slide, despite the significant expansion in donor registries over from 1987 to 2017, if you are not a white European, your chance of identifying a suitable matched unrelated donor drops significantly. And that makes life very challenging. And since more recently, in the last few years, registries have tried to expand their donor pool who are non-Caucasian, but despite this, the challenges remain. So like others, we also were very keen on moving to expand our haploidentical program. This EBMT slide shows a trend analysis of the change in the choice of donor type across Europe from 1990 to 2019. The light blue line here represents haploidentical transplants. And as you can see, from about 2010, it has really taken off in largely replacing cord blood transplantation as the donor of choice. And this would be true of our program as well. So advantages, very obvious: immediate availability of one haplotype mismatched donor for virtually all patients that we hope to transplant within the appropriate time frame, and of course cost, which in the NHS is a major consideration. The cost is substantially reduced for a haplotransplant as for an unrelated donor transplant. The impetus for this was the post-transplant cyclophosphamide protocol, originally pioneered by the Baltimore group, where you can modulate both the host versus graft and the graft versus host reactions by directly deleting alloreactive T cells while preserving regulatory cells. So the protocol given below is largely what is a published one, and we largely follow this protocol, except for individual case-by-case tailoring to patients. So cyclophosphamide is given on day 3 and day 5. In terms of donor selection, this is a summary slide. It also appears in our guidelines and the EBMT guidelines. So for T-cell, in vivo T-cell depleted transplants, which is what I'm largely going to talk about today, considerations that are mainstream are, first of all, no DSAs. We try and choose an NK cell alloreactive donor, a younger donor over an older donor, male for a male recipient, and first-degree relatives, and in order to harness the NEMA effect, which is the non-inherited maternal antigen, and I can provide an explanation if you need me to later on. We choose the mother as a preferred donor where possible. ABO mismatch and CMV are also considerations, although CMV has become less of a consideration with the NICE guidelines now allowing for the prescription of prophylactic CMV drugs. with that in mind, alloreactive NK cell donors are, of course, an attractive option where multiple related donor choices are available. Just to set the scene, the KIR genes are the second most polymorphic gene complex behind that of HLA. You have four framework genes which are present in every individual, and then other genes which are present or absent based on the person's genotype. So the interest is that KIR genes can be classified broadly into A and B haplotypes based on the presence or absence of activating genes in the centromeric or telomeric region. So the ligands for the KIR genes would be HLA molecules such as A11 and a BW4 motif, which is present across a whole set of HLA class 1 molecules, and is centered around the position 80 of the HLA molecule.
Recording in progress.
Did someone say something? I shall carry on. So we were looking to understand, there's been a lot of studies published over the last couple of years where KIR B content of donors has shown to be beneficial when chosen as a donor in order to improve transplant outcomes. So we wanted to test that theory in the haploidentical cohort with in vivo T-cell depletion using cyclophosphamide. There have been much fewer studies published in this cohort because the haplo programs are growing in the UK at least, but no one center usually has sufficient patient numbers to provide clear data on this. Now that we have about 77 haploidentical donors, and we chose 2015 to 2020 as the year range to choose from because we know that the induction and post-transplant management protocols are largely standardized across these years. So there was less variability in our donor cohort. And we found that when we type these patients using SSO for their KIR gene content, I think I might have missed the slide. I'm just going to go back one. So we type these patients and donor types using SSO, using the Luminex platform, in order to test the theory, as I said, that the KIR B content donors had beneficial impacts on transplant outcome. There is an open calculator which is available, which can be used to calculate the KIR B content. It's based on the work published by Cooley et al. And that's what we used to categorize our donors into neutral and better and best donors. So we had to put the better and best donors together because the numbers were small. So we were comparing neutral donors with better and best donors. So just looking at the patients, we had 77 haplo patients with PTCI. Most of the patients had myeloid conditions with a smaller proportion with lymphoid malignancies. Calculating the EBMT score, the patients ranged from intermediate risk to a small proportion of very high risk patients at the time of transplants. Most of our patients received reduced intensity conditioning because of the age in many cases, and a fewer smaller cohort received myeloablative conditioning. We had an average follow-up period of about 400 days. So if you look at our data, this data is very different to what has been published in the unrelated matched donor setting. So we found that donors with KIR B content actually conferred an increased risk of relapse after 3 years. It's a small sample size, admittedly, but it was a significant difference. Now, this is quite different to many of the papers published in the unrelated setting. While we couldn't establish a statistical significance, there was also a trend towards increased infection episodes in the better and best group. And just to remind us that the better and best group are the group with a higher KIR-B activating KIR content and would be defined as the KIR-B genotype. Overall survival was also significantly reduced in the better and best group and compared to the neutral donors. So all these were slightly surprising and contradicted some of the published literature, but which are largely in the unrelated matched donor setting. So looking into a bit more, our conclusion was that better and best donors do not, in this particular cohort, impact incidence of either GVHD or non-relapse mortality. And thinking about the reasons for this, post-transplant cyclophosphamide eliminates most alloreactive mature NK cells, which are infused with the graft, as well as the T cells, which is the primary cohort that's depleted. So which means that immediately post-transplant, after day 5, cyclophosphamide is given, the amount of donor NK cells that are alloresponsive in the infusion in the patient would be very minimal. NK cells need IL-15 cytokine environment to mature and proliferate. And the donor-derived regulatory T cells are not often impacted by the PTCI. They can protect themselves as the stem cells can. And this could hinder donor-derived NK cell maturation. So in order to track this, we are starting a project to track donor NK cell maturation and dynamics in the patient post-transplant. So this will be a Ph.D. project, and we have just started applying for the ethics of this. Another major consideration when selecting donors for haploidentical transplant in our cohort will be donor-specific antibodies. So obviously this is associated with a 10-fold increased risk of graft failure. Prevalence of DSA is lower in male, obviously, compared to female recipients. And we have patients who undergo desensitization therapy where the DSA MF5 is shown to be above 5,000. We test for DSA using the Luminix single antigen bead guidelines, beads which are provided by One Lambda. And on a case-by-case basis, if required, and I hope to illustrate this with a case study shortly, we also perform cross-matching using donor-derived lymphocytes and patient sera at various points in the workup period. We use both CDC cross-match and flow cytometry cross-match for this. We would also continue to monitor DSA post-antibody removal and post-transplant if indicated. So it seems like a very expensive exercise to undertake. As I said, I hope to illustrate why this is in place in the next few slides. So this is a donor who, a female patient, about 43 years old, had multiple haploidentical donors, 3 of them, 2 siblings and her son, who is 20 years old. For various donor fitness related reasons, the siblings were not suitable in the end, although the patient had DSA to all 3 donors. So it was a choice of worse, and even worse. So we settled on the son for reasons of fitness. This antibody, the B7 antibody that is in this graph, starting at 20,000 MF5 and in a neat serum, is pregnancy-related antibody. So that was a major concern for us. So we did some dilution assays in order to inform the clinical team on their planning for antibody removal for this patient. There was some clinical urgency to the transplant happening because she was in remission. So we were doing all this late last year very quickly to support the clinical team. So as you can see, we had to go down to a dilution of 1 in 128 in order to reduce the antibody DSA levels to below 5,000 MF5. So this gave the clinical team a good indication of the number and rounds of plasma exchange and other antibody removal that they needed to plan for this patient. So this is the kind of planning we did. We worked with the clinical team to make sure that they were aware of the need to send repeated sample for DSA assessment throughout the antibody removal process. They were treating the patient with both IVIG and rituximab, which can interfere with the laboratory assays. So that was another consideration in terms of when the sampling was done and how the laboratory took into account the treatment plan into their testing regimen. So we tested the patient and ignoring the C7 antibody, which was not as significant as the HLA-B7 antibody, which started at 20,000, and post antibody removal, the first round came down to about 4,000 MFI. That would be cross-match positive in a solid organ setting. But then a few days afterwards, there was a rebound of the antibody, and they had to do another round of antibody removal. So we tracked the antibodies till it stayed stably low, and then the stem cell infusion was given to the patient. We then continued to look for these antibodies post-transplant for a few weeks till they were sure that the antibody was not returning, and the patient successfully engrafted on day 31. And this was a lesson learned for everybody concerned, because previously we have transplanted across DSA with minimal input from the H&I laboratory, and the transplants have not been successful in the most part. So that was the lesson. And in addition to just the antibody monitoring, we also did cross matches. And I'm going to go back a few slides. At the start of the antibody removal process, and as you can see, the flow cross match was positive all the way down to 1 in 8 serum dilution, and the CDC cross match only became negative. So CDC representing cytotoxic antibodies became negative only at the 1 in 4 dilution. So there was clearly a big burden of IgG positive cytotoxic antibodies that needed to be taken into account as part of the antibody removal plan. And post-transplant, at the point of stem cell infusion, the flow cross match was negative at meat, as was the CDC cross match, which was a reassuring sign. So another thing that we have started to consider as we expand the haplotransplant program is HLA loss. Again, I thought a case study might illustrate our experience better. So this was a patient with AML who received it's a young patient, 35 years old, who received a haplotransplant from their brother in 2018. And just ignoring the HLA here, just 2 haplotypes, 1 shared haplotype, and 2 disparate haplotypes. So in November 2020, the patient relapsed. So we have, since about 2019, we've implemented NGS HLA typing, and this came in useful in this instance to illustrate the point. So post-transplant chimerism was performed as routine standard of care practice, and it showed that there were 20% donor cells in the patient's whole blood, whereas the T cell compartment was still largely donor. And flow cytometry results detected 80% CD34 blasts. So the question was how to treat this patient, and we were sent a post-transplant HLA typing sample, which is not standard of practice. And when we typed this, we could not detect the haplotype in green. And just to remind us, if I just go back, this is the donor, and this is the patient here, and this is the donor. And this is one of the mismatched haplotypes of the donor, which we now could not detect. It vanished completely. And when we looked at the NGS results, and forgive me, this is a very busy slide, but just the highlights to take away, we could see the missing haplotype at very low levels in the analysis graphs. So clearly, the patient had lost the mismatched haplotype as an immune evasion response. Because a lot of this was inferred from data, we just wanted to see if we could use a functional assay to corroborate our inference. And we had marrow aspirate from the patient, and we had antibodies to, patient was very conveniently HLA-A2 and A3 HLA type. So we were able to access some antibodies and demonstrate that when we stained with an A2 antibody in a healthy control, you could see A2 positive cells. When you stained the patient, again, this is only 20% donor cells. So you could see some A2 again in the post-transplant sample, but healthy control could be stained with A3 antibody, and the patient post-transplant had very few representation of cells which bound to the A3 antibody. So that further demonstrated that there was loss of HLA. So this was very useful to the clinical team. We just confirmed it using a buccal scrape sample from the patient. But it was very useful to know because they were at the point of decision making as to whether to give the patient DLI or choose an alternative method of treatment. So we turned this around very quickly, and the DLI was suspended for this patient because it would have contributed to increased GVHD without any benefit of the GVL response that they were hoping for. A second transplantation was instead worked up very quickly from a different HLA haploidentical donor. The second donor, who was also a sibling in this instance, was selected for mismatches again of the HLA haplotype that has been retained by the leukemic blast. This was in order to harness the potential GVL effect. So that was a whistle-stop tour of our considerations in choosing a haploidentical donor for our patient cohort. So I'm happy to take any questions, and I'd be very interested in your views in a discussion. Over to you, Srini.
Yep. Thanks. Thank you very much, Arthi. That was quick, and I think I loved the case presentation. That added more value to the whole exercise. If you have any questions, please post it in the chat box, type it in the chat box, and we'll pick it up while they arrive. I have probably a couple of questions. One, I know, but you mentioned that, if I understood right, that the haploidentical transplant became a necessity because in the difficulty in finding matched unrelated donor for the South Asian population, especially. If that is the thing, is there a difference in the number of haploidentical transplants that's being done on the this ethnic group, which doesn't have that many number of donors globally, potential donors, versus the Caucasian? Is it something necessary for this population more than the Caucasian population?
Yeah, that's a very good question. So so two things I think kind of triggered the expansion of the Haplo program. As everyone in India will know more than me, this is not a new thing. Sometimes you don't have donors, as is the case largely in India, and you would do a haploidentical transplant for want of any other options. Of course, in UK, and that would be my experience, I'll speak from the UK point of view, this was not a norm because of the high levels of GVHD that you would have to manage and the very poor transplant outcomes. I think it was the post. So there were several programs started with ex vivo T cell depletion, but it is a very cumbersome and expensive process and needs a GMP facility. So it wasn't really viable in terms of scaling up haplotransplants. But with the use of post-transplant cyclophosphamide and being able to manage in vivo T cell depletion, that's what really provided the boost to expand the programs. And you're right, it is largely led by demand from the non-Caucasian communities, where we can inevitably find them at 12 out of 12 matched donors. Imperial also has a very large program supporting transplants across the Middle East. So we, particularly in our pediatric cohort, we transplant a lot of immunodeficiencies, Diamond-Blackfan anemia, sickle cell, and again, in these cohorts, it's very hard to find transplant donor choices that are, of palatable to the clinical team. So it's good to have the haplo option.
Thank you. I have a question coming in from Dr. Aruna Rajendran, who is a busy transplant physician from Chennai. Does HLA matching in class 1 or class 2 amongst the potential haplo donors with the patient affect the transplant outcome? Does HLA matching in class 1 or class 2 amongst the potential haplo donors with the patient affect the transplant outcome?
I know possibly, and I'm speculating here, the question arises from the fact that historically we wouldn't type across both class 1 and class 2 or loci. But now, at least in the UK, all patients worked up for transplants are typed across at least 5 loci, HLA A, B, C in class 1 and DR, DQ in class 2. In our center, we go beyond that and we also perform DP typing as routine. So when identifying a haplodonor, we would type a range of potential options and then work out which donor was better than haplotype, if that makes sense. So have the least number of mismatches at different loci. And that's the selection criteria for us. In a way, it's not a huge consideration with post-transplant cyclophosphamide, but I think it just helps manage chronic GVHD more than any acute phase interventions.
Thank you. There's one other thing your clinical person, the case discussion pointed out is the use of donor-specific antibodies, pre and post-transplant, which at least to my understanding, I have not seen this practice here. So I do understand that DSA is becoming more and more a routine test in haplo especially. Am I right?
Yes, so in the latest iteration in the UK, it has become almost mandatory. So the guidelines strongly suggest evaluating DSA and monitoring DSA with antibody removal and then post-transplant monitoring. And this is, we have been burnt many times. This December was the case I presented. And the December before, we lost 3 patients who had DSA and had haplotransplants. So it's an evolving collaboration between the HNI laboratory and the clinical team. So we guide them as to the rounds of plasma exchange. I didn't touch on it in my talk, but apheresis and plasma exchange is limited by the units available and the timing. So the more you can plan with your local HNI lab and have the patient come in for their apheresis and plasma exchange, the better it is for all concerned. So it's something that's been evolving. So now the clinical team know that we are able to guide them. They make full use of it. And I'd be curious to know how this is addressed in the setting you all work in.
As I said, I haven't seen DSA being done in haplo. Dr. Aruna, would you like to address it? With reference?
We do a DSA for all haploidentical transplants. So actually previously we used to get commonly negative reports, and it was easier for us to just proceed. But nowadays, I don't know, because of using such very sensitive assays like mentioned, like the Luminex assays, we are now getting positive donor-specific antibodies also. So the last case we did in the previous week, the child has donor-specific antibodies of around 4,500 MFI. So we are looking for other potential donors because it is very difficult to, it is very expensive to bring down to use the plasma exchange rituximab pre-transplant.
Yeah, absolutely. I fully identify with your experience, but as our transplant lead, Professor Aluwaria said to me, ignorance is bliss, but now I know I cannot overlook this component of donor selection. So yes, it has added quite an incremental burden to everybody's budgets to take this into account. Something else that I hadn't included in the case study, but just thought worth mentioning, we are also for high-risk transplants, such as the one with DSA antibody removal, we've started collecting auto stem cells as a rescue remedy, so to speak, early on before antibody removal, because again, we've had instances where there was nothing we could go with. Unrelated donors are not an option because of the challenging patient HLA type.
Thank you. Is there anything else coming up? Okay, if tomorrow you have a question, please don't hesitate to email us. You have our email ID. Maybe we will try to get the answers. The purpose of interactions like this is to improve the outcome of transplants as far as this country is concerned, and more specifically this city is concerned. So, and I'm not sure whether it's right making this statement, but I still would, I know, Arthi, you will know where I'm coming from. I think there is an urgent need. Haplo is an answer, I agree, but I think there is an urgent, unquestionable need to sort of create a larger Indian registry with committed donors. I think that cannot be taken away just because Haplo is now available. Haplo is improving, the outcomes are better. I think we do need a good registry in this country.
If you would permit me, I have a question, sir.
Yes, sir, Dr. Arna.
So it was a very nice presentation, madam. It is a very challenging topic. And every day we are learning something based on the patient experience. So actually, because of the consanguinity, because of the same caste breeding, it is not uncommon to find 8/10 matched mother, 8/10 matched father, and one of the parent will be 5/10, the other parent will be 8/10. So, is there a difference in outcome when we use a better match? Is it actually that is what we often tend to choose 8/10, but is it better than 5/10?
Absolutely. As I said, we would choose an 8/10 over a 5/10 every time. And again, while the immediate post-transplant complications with relation to GVHD are taken care of by the cyclophosphamide, chronic GVHD is ever a consideration, and that's what you're trying to solve for when you find the lesser mismatched donor, because as I'm speaking to the converted, I'm sure, as you are much aware, you have many things you can do early on in the post-transplant process to deal with GVHD, but the options diminish as chronic GVHD comes into play. And so, yes, that would be the consideration that would direct us to choose the better match donor if that option was on the table.
Okay.
Thank you.
But it's not, sometimes it's frustrating that the principles don't translate into practice. We are currently working with an Afghanistan family with an immunodeficiency and 6 children, 3 of which who need a transplant. And one of them has got, one of the siblings is a fully matched donor to one of their siblings. So there we still have 2 more that we are struggling to find donors for. So you would think with 6 siblings, you have a good chance of finding a donor, but apparently not.
Yes, anyhow. So thank you very much. If there are no more questions, I just would like to thank Dr. Arthi for accepting this and this for interesting, crisp, short presentation, which is, I'm sure that we are taking home a couple of messages here in terms of donor selection, in terms of tests that we use and how often we use. I know that some of them are not practical, maybe what you call is going to get into the budget which you have to treat. I think we need to find a way as far as the budget is concerned, if the right thing needs to be done, that we can always sit and discuss. And thanks again. And for your information, the program has been recorded and it will be made available in a couple of days. And you could get into the Jeenomics channel in YouTube and it should be available. Just give us a couple of days to post it there. Thanks a lot. Thanks, Arthi, again. And good night, everyone. Thank you.
Thank you very much. Good night, everyone.